Hi, everyone. Again, I'm Hilary Robbins. I'm from the International Agency for Research on Cancer, part of WHO in Lyon, France. You all have done something very dangerous, which is ask an epidemiologist who studies early detection to give a presentation about staging. But I'm going to try to, like Maurizio, I'm going to keep it quite conceptual and try to talk a bit about how biomarkers should be studied, let's say. I'm going to begin with an oversimplification of early stage lung cancer to give us a bit of a framework to think. Let's consider that early stage lung cancer could be broadly grouped into three categories. The first, early stage, overdiagnosed, indolent disease, not going to harm the patient. Second category, early stage, well-behaved, treatable, curable. Third category, early stage, we treat it, but it's more aggressive than we thought, and perhaps it goes on to lead to death despite treatment. Using this oversimplification, the typical behavior of blood biomarkers is that they sort of increase as we go across these categories. And remember, biomarkers, no matter what anybody tells you, are not yes or no. They have almost, without exception, some underlying continuous distribution. So often they behave like this, although not always. And I talked yesterday about biomarkers for early detection. And what often happens is that biomarkers are developed for the purpose of early cancer detection, and then they're found sort of on the back end to have some kind of prognostic value. And in general, prognosis is actually a much easier problem for a biomarker than early detection. Biomarkers for early cancer detection are one of the most important challenges I think we have in cancer research. And in general, prognostic biomarkers are earlier to find. There are exceptions to this, and the protein panel that we developed, for example, we found does not seem to correlate with prognosis. To give you one example, I'm going to present some data again for the Gallery test developed by Grail. This test is based on methylation analysis of cell-free DNA. I presented yesterday the data on the left side for the early detection setting, but these are diagnostic samples, so these are samples collected at the time of diagnosis from lung cancer cases. And we saw that the big challenge for this test in the early detection setting is low sensitivity for early stage disease. Last year, some data were published for the utility of this test in the setting of prognosis. So on the upper figures, we see relapse-free survival. On the lower ones are overall survival. On the left side is clinical stage 1. On the right side is clinical stage 2. And for the stage 1 adenocarcinomas, we see that the survival of the biomarker negative cases is much better than the survival of the biomarker positive cases. The same doesn't seem to be true in the stage 2 cases. I don't have time to show you, but this result was reproduced for a completely different cell-free DNA assay. I want to mention the distinction between different types of biosamples and what we can learn from those different study settings, different types of biosamples. So first, we have diagnostic samples. We have blood samples that were collected at the time of diagnosis from cancer cases. Second, we can consider population cohorts. So these are biospecimens that were collected from people when they were cancer-free, and then those people were followed over time. These types of cohorts are kind of the driver of epidemiologic research, and these are the types of settings that we work in my team. And then finally, we can think about biospecimens collected from lung cancer screening participants, which is what many of you are doing nowadays. If we think about the diagnostic samples, of course, what we're going to learn about the utility of biomarkers for staging depends on the stage of those cases from whom the blood was collected and the mode of diagnosis. So I think it really depends. Population cohorts are a sticky one because in general, cohorts of people, these are unscreened people. So in general, whatever we learn is going to be about clinically meaningful disease because there's no overdiagnosis because they're not screened. However, we're learning something in an unusual setting because the blood is pre-diagnostic. So we learned something prior to diagnosis, but about disease that is eventually diagnosed, usually at late stage. So it's a bit of a mixture of two things that is complicated to think about. And finally, for screening participants, these are important because we can learn about these different groups of early stage disease because we should have all three. But we have to consider the fact that some of these cases may be overdiagnosed And for an individual, it's almost impossible to know who is overdiagnosed and who is not. In the setting of a randomized clinical trial, we can measure overdiagnosis and long-term follow-up, but for an individual person, it's sort of a counterfactual problem. We never are quite sure. So I'll close on some comments about trying to build resources that can move us forward in evaluating the utility of biomarkers for prognosis in stage 1 lung cancer. First of all, try to collect blood systematically from lung cancer screening participants and those who are diagnosed with lung cancer in order to avoid selection biases in the groups of people in whom we have blood. Very important, consent these participants to broad future research of their data, of their biospecimens, and of their low-dose CT images, including international sharing, including genotyping, and permanent storage. Try to apply multiple protocols for the blood processing if it's feasible. The blood processing requirements for different biomarkers can be very specific, and this is one of the challenges when we try to study their performance. But in broad strokes, you can consider plasma, serum, potentially Streck tubes. The sort of pre-processing time, so the time that the blood spends on the bench before you spin it down, is really important, is a very kind of challenging implementation consideration, but it's difficult to build into protocols. Store samples at -80 Celsius or on liquid nitrogen, and of course, link biospecimens to detailed clinical data. So this should include detailed information on participant demographics, smoking, risk factors, and comorbidities. I don't think we mentioned this, but for lung cancer patients who are currently smoking, the most powerful drug is smoking cessation. So we need to show that these biomarkers can give us more information than smoking, just as we do in risk prediction. Link them to the LDCT scans, data about the nodules, of course, collect detailed data on the lung cancer diagnoses, and finally on survival over time. I'll stop there.
Right. Well, Fred has his hand up, so I guess we have to honor it.
So the role of biomarkers in the staging system should need a longer discussion. First of all, I don't think the staging system per se make the outcome for the patients. The outcome for the patients is made by the treatment. And the role of the staging system is to secure that patients are treated in the same way based on the staging system. I agree with that one. So staging system should be objective, but the treatment is kind of evolving the whole time. And here comes the question in with biomarkers. Because what we are dealing with biomarkers these days is not necessarily prognostic perspective, but predictive perspectives to certain therapies. And that is a big difference. And I would like, Karen, you know, we have spent years in the molecular subcommittee to gather those information and a database. And that might be the only database you can get for untreated patients looking at the prognostic implication of the biomarker and not the predictive implication of biomarkers. So biomarkers has, in my opinion, something to do with the treatment. But the TNM system is more objective and stable and make it possible to compare studies, different studies, harmonize the grouping, but treatment aspects, including biomarkers, is a different story.